Good afternoon, everyone. Thank you for joining us on the, I think it's our third now, COVID First Responder PPE Exposure and Q&A webinar. Can you guys hear us okay? Do a quick sound check. Okay, looks like we can hear. Great, thank you. So just to remind everybody who's on the webinar today, again, it's the same as it was on Friday the 13th. We have Dr. Lehrfeld returning, State EMS Medical Director and ER Physician, and Dr. Rebecca Pierce, who is, let's go in here, Healthcare Associated Infections Program Epidemiologist here at the state and working with the COVID response. And you have myself, Rebecca Long, Mobile Training Unit Coordinator here at EMS and Trauma. So again, thanks everybody for joining today. We have an hour-long webinar. We're going to hit a bunch of the highlights and what's changed and what's new. One thing that has changed slightly with the webinar process, if you're viewing in a group, at the end of the webinar, we have you answer that question stating to sign in everyone's name and email address. If you're viewing in a group at your agency, feel free to create a roster for that agency and just have your training officer sign it. You can skip the step of having us generate certificates for you, again, if you're at one of the agencies that has a training officer. If you're still non-affiliated or don't have that capability, please just fill out the survey and we'll get you a certificate. One thing I did want to point out, oh, hang on, if I didn't unpause my screen, sorry. Sorry, everybody. Is the website looks a little bit different when you go to visit it, just for capacity. They changed the website a little bit, but it's basically the same. If you go to look up for any EMS or healthcare documents, this is what the landing page looks like now, and you'll just click on that yellow tab on the right for healthcare and local public health. And we're actually going to visit that site here during the webinar and show you a couple different documents. Looks like there's quite a few handouts in there. There's 5 for you guys, and some people are saying that the law enforcement one isn't working. I apologize for that. I will show you where you can access them on the website because they are listed. So forgive me for them not working in there. So we're just going to go over a couple tidbits of news and information from the EMS office as it pertains to COVID. EMR, ambulance agency and vehicle renewal opened today, April 1st. It will run through June 30th. Right now, EMR is scheduled to close on June 30th. We will revisit that as we get closer if we need to change that date. But again, right now, EMR renewal will close on June 30th as normal. If EMRs need extra CEU hours or any providers need CEU hours, in the handouts, we have the iLearn Oregon Account Creation Guide and a watching webinars on iLearn. Again, these are all of the archived webinars that have been recorded and placed on iLearn Oregon. This is a free site to you guys. It's the learning site that we use as state employees. And so again, there's over 45 webinars there you can go and access. Please remember watching recorded or archived webinars count as that distributive education, so no more than 50% in any category of Appendix 1 can be obtained this way. Another way you can get education is through Boundary University. They have free CAPC accredited courses that you can access. Another thing for NREMT licensed folks, they have extended their current recertification deadline from March 31st to June 30th. So if you haven't renewed your NREMT license, you have more time. Again, you don't need that to practice in Oregon, but we have quite a few providers who are licensed at the NREMT level. In other news, OHA, EMS, and Trauma is partnering with several of the conferences around the state, the Eastern Conference, Newport, and State of Jefferson EMS Conference, because as you guys know, these were canceled due to COVID. We are creating a virtual EMS conference. This is airing next Friday and Saturday, April 10th and 11th. Sorry, it'll be a week from now, April 10th and 11th. Put it on your calendars, please. Watch for emails from us. You will get more information. We're going to host these like we do webinars Each speaker, we have up to 10 so far. Each speaker will have its own GoToWebinar link, and you will sign up for the classes that you want to take. So please, again, keep an eye out for that. It'll be a great resource for everybody, and we thank the conferences and all of the people that are associated with those conferences, and Stella, who's setting all this up to provide CE for everybody. We're hoping to have another conference again in a couple weeks after that to provide CEU during this time, because we know it's hard to gather, and getting training hours at your agencies is difficult. Lastly, one other thing that we are looking at is CPR certifications. It is required in the state of Oregon to have a current CPR healthcare provider card to practice as an EMS provider. If yours expires during this time, we do expect that you do everything you can to find a local instructor to give you a course and to maintain that card. Please, again, just find someone that can hopefully teach the course in your area and provide a class to a smaller number of participants, respecting the social distancing guidelines. Another EMS news. OHA EMS and Trauma is working to draft emergency rules to allow AEMTs and paramedics to hold a provisional license who have completed their educational programs, sat for the cognitive exam, and were issued a provisional NREMT license. Again, this is something that we are drafting emergency language so that we can apply close to 300 to 400 new EMS providers staffing in Oregon. So for them to qualify for that, again, they have to have completed their program, sat for the cognitive, and have been issued a provisional NREMT licenses. So lots of questions we had around first responder testing. I want you guys to know that as you are designated as healthcare workers, you are prioritized to get tests if you're showing symptoms. If you're asymptomatic, you do not need to go in and get tested. I'm going to show everybody on our website too. There's some documentation that you can print off and take into your primary care physician if you need documentation and you're symptomatic and you want to get tested. On our website. So again, I'll show you guys, this is the landing page for the COVID-19 updates. Please bookmark this and have this on your computer. It's a great resource to have. It's updated daily. I think Dr. Learfield was updated 10 minutes before the webinar started with new documents. So we'll go to this link here on the right for local public health.
It is updated as needed as guidance and new information changes. So that could be several times a day.
Yeah. Right here is where you guys, all of the information that we're listing is for EMS, PSAPs or your dispatch centers and law enforcement. But if you need support documents to take to your primary physician to get testing, you'd go under healthcare providers and clinical laboratories. And it's this first link here for health systems regarding COVID testing. Again, I can only upload 5 documents into the handout, but this is where you guys can access this. And this document does state, if you scroll down right here, for clinicians, suggested groups for testing are healthcare workers. So you guys fall under that. So you have this document if you need it, you're having trouble getting tested, and you are, again, symptomatic. Some labs are starting to expedite the test. Again, it's lab dependent. I think you'd have to ask your primary care physician or clinician what lab they partner with, but some labs are trying to expedite the test for healthcare workers. One thing the state lab did ask is please don't call, and you can let everybody else know this too, please don't call and asking where your sample is or your test is. They aren't getting all of the tests. They are going to private labs now. So please ask where your sample is going so you can make sure to follow up with the appropriate lab.
Right. The clinician who sent the test is responsible for informing you of the results.
Yes. And how long is that lab and physician dependent right now?
It's lab and physician dependent.
Okay. Perfect. And forgive me, you guys, we're kind of going through the slides, and I see that you guys are asking questions, so I will make sure and go back and get through the questions as we're answering some of the registration questions and follow up with you guys. So I see that you guys are typing them in, we'll get to them. Another thing that we will talk about, we're going to have another webinar next week. It's going to be directed at mostly transporting agencies, but there have been new CMS waivers that have been issued for ambulance transport, transporting to alternate destinations, and payment that's associated with that. But we figured with this webinar, it's directed more at you guys are frontline staff, PPE exposure. So we're going to have a separate webinar on this. Again, watch for that information to come out, but that'll be next week. The CMS document is included in the handout. Hopefully it works. And you guys can access that if you want more information on it right now. One of the other handouts, and again, forgive me that it's not working, was the law enforcement healthcare exposure. There are some differences in that document. Let me see if I can pull it up again for you guys and show you where that is. Again, on the state website, drop down for EMS. All of the documents that I have uploaded are also right here. EMS healthcare exposure, work exclusion guidance, and the law enforcement work exclusion guidance. So you can download those there. And again, see, it was updated today, the EMS one, and there's a law enforcement one that this needs to be updated to today as well. So again, please keep checking back to our website, as this is where you're going to find the best information. Back to our presentation here. Okay, so going into some of the notifications for exposure, same thing, nothing's changed since last time. The lab would notify the local public health authority in your area that your test or someone's test is positive, and they should be contacting the agency. So nothing has changed there. But please remember that sometimes patients that we transport might not develop symptoms for days after we transport them, and then they're tested. So it can be even more time after that that you'd ever hear that you transported that patient that was actually positive. The minimal personal protective equipment, this hasn't changed. Goggles and face shield, and 95 masks, gloves, and gowns, especially when doing aerosolizing generating procedures. The work exclusion and monitoring. So basically, you guys can read the slide. In the context of this, all healthcare providers should self-monitor for illnesses consistent with COVID. We could be treating and transporting patients that don't show any signs of COVID at that time, but still can be contagious, and we might be exposed. So please, you should still be allowed to work, and the guidance here does say, unless you're showing signs and symptoms, you should be able to work, but monitor yourselves diligently for symptoms. The self-monitoring does consist of measuring temperature twice daily and evaluating for any of the following signs. So again, a temperature over 100 degrees Fahrenheit, cough, or shortness of breath, as those are the most common signs and symptoms we're seeing with COVID at this time. So again, even if you think you were exposed, you still can work as long as you're not exhibiting any signs. If any of these signs or symptoms develop, you should not come to work and notify your supervisor immediately. If the symptoms develop at work, please withdraw from patient care immediately. Don a face mask if you're not already wearing one, and notify your supervisor or occupational health services prior to leaving to work. Healthcare providers with acute respiratory illness should stay home until 72 hours after resolution of the fever and cough, and without the use of fever-reducing medication. Mildly symptomatic healthcare providers are not required to seek care solely for the purposes of testing, but you should do so if you require medical evaluation or intervention. So if your condition worsens enough to where you need treatment. Agencies should educate on the appropriate monitoring for symptoms, instruct providers on how to monitor for fever and respiratory symptoms, stress for your employees not to come to work if they're feeling ill, and ensure that all healthcare providers have thermometers or access to a thermometer and masks if they become symptomatic while on shift. If you're seeking care, the healthcare provider should first call your healthcare provider or local hospital to inform you that you're being monitored for COVID-19, and they'll follow up with medical testing. Your healthcare provider will advise you on the next best steps. You don't always need to come in. Again, it depends on your signs and symptoms. And a lot of the facilities now have special entrances and special testing procedures. Some of them are drive-through, so they will advise you on the next best steps. So we'll move into some of the registration questions. And again, I want to thank everybody for taking the time to submit questions. They're amazing questions. We do go through all of them. I apologize if we can't answer them all, but we are doing our best to get to the most popular questions because there are a lot of repeats. So we'll welcome Dr. Rebecca Pierce to answer some of the first questions.
Hi there, Rebecca, can you hear me okay?
Yeah, you sound great.
Okay, great. Hi, everybody. Thanks for having me again. I'm just going to read the questions that I got and answer them as best I'm able here. So first question, can you provide actual data of pre-existing conditions? Is smoking, vaping, obesity considered risk factors? So I'm going to list the major risk factors for severe disease from COVID. So that includes people over the age of 65, those who live in nursing homes or long-term care facilities, those with chronic lung disease or moderate to severe asthma, those with heart conditions, those who are immunocompromised, people with severe obesity, so this is generally considered a BMI of 40 or higher, those with diabetes, chronic kidney disease, or liver disease. Specifically related to the question about smoking, so no data that I'm aware of on the risk of smoking and COVID. However, smoking is in general considered a risk factor for respiratory illness. It's known to disrupt the mucosal physical barriers and can impair the immune response. Influenza, for example, the risk of influenza is 7-fold higher among smokers compared to not smokers. The next question, any additional worries for pregnant pre-hospital providers? So per CDC, we do not currently know if pregnant women have a greater chance of getting sick from COVID than the general public. There are pregnant individuals that have presented with mild illness to date, but these are mostly anecdotal reports at this point. Pregnant women in general experience changes that may increase their overall risk of other infections. So I think CDC and us are taking a cautious approach to this. We do not know if a pregnant woman with COVID can pass the virus that causes COVID to the fetus or the baby during delivery. No infants born to mothers with COVID-19 have tested positive for the COVID virus to date. But these are very small numbers at this point, so information is still coming in. Also, to date, the virus was not found in samples of amniotic fluid or breast milk. Are first responders required to get any specific vaccine for this if exposed, and will this be covered? So no, there is currently not a vaccine or specific medications to treat or prevent COVID-19, though research is underway to develop vaccines in many areas throughout the world. Are there guidelines about how long the virus can live on surfaces? So there is still no definitive evidence on this. Generally, the consensus is hours to days. There are some wide variations of what's being reported in the scientific literature. I will cite a recent New England Journal study, and I'm going to caveat this pretty heavily after, but they reported that the virus was viable for up to 72 hours on plastics, 48 hours on stainless steel, 24 hours on cardboard, and 4 hours on copper. However, my two important caveats. For the plastic one in particular, because I think this really caused a lot of concern, at 72 hours, only 0.1% of the starting viral material remained. So infection is theoretically possible after contact with these surfaces without washing your hands and then touching your face, but is very unlikely at the levels remaining. We're still talking about more likely scenarios of contaminated surfaces being relevant on the hours range. In addition, cleaning surfaces with soap and appropriate disinfectants is extremely effective. The virus has an oily outer layer that if you disrupt will render it inactive. And the important part is really that disinfection of high-touch surfaces happens frequently. So this includes all patient care areas, ambulances, patient beds, handrails, and then general equipment in the home as well as in the workplace. So tables, doorknobs, light switches, countertops, handles, desks, phones, keyboards, toilets, faucets, sinks. And always a really important way to protect yourself against any contaminated surfaces is washing your hands. Next question, what about aerosolized droplets in areas where we have air movement? So generally, droplets from coughs or sneezes are too heavy to remain suspended in the air. In general, the role of aerosols with COVID-19 transmission remains uncertain. WHO reports that there has not been evidence of airborne transmission to date. However, and I think we all will recognize this, it remains plausible that some procedures may generate aerosols and increase the risk of transmission. So given the close confines of EMS-based and first responder-based care, frequency of procedures that generate aerosols, a respirator, eye protection, gown, and gloves continues to be the recommendation. Next question, can I work during the latency period before viral shedding begins? So those with fever or respiratory symptoms should not come to work. One of the challenges with COVID-19 is there is an incredibly wide range of illness presentation. So some may have mild fever and cough, and others may have more pronounced respiratory symptoms. The important thing, again, is to avoid coming to work if ill, even if symptoms are mild. I will note here that in some studies of the COVID epi situation in other countries, only about 40% of those presented with fever at the beginning of their illness. Almost everyone develops a fever that has COVID at some point while they're sick, but not everyone presents with that on day one. So just keep in mind that when you're self-monitoring for symptoms at home, fever checks are really important. But they are not the only symptom to monitor for. You also want to be keeping an eye out for cough, shortness of breath, sore throat, etc. We know that some individuals can test positive for COVID-19 before their symptoms are detectable. So this might be because they have such mild illness or don't have the predictable set of symptoms that has been associated with COVID. However, we do not know the role of the individuals that test positive at this point play in transmission. In general, those that are coughing or sneezing or have excess secretions are likely to be releasing more infectious droplets or contaminating the environment. So guidance about work exclusions and things like that is generally focused on these individuals who are symptomatic. However, as always, your employer may wish to do work exclusions for those who have high risk exposures and may do things like recommend a regular mask to wear when not wearing an N95 for patient care while during your incubation period. Next question, does the 72-hour rule apply for fever only symptoms or fever and respiratory complaints? So I assume this references how long individuals should stay home and out of work when they are ill. So to simplify, we now recommend that all ill individuals, including those confirmed to have COVID and those who are not tested, stay home for at least 3 days since resolution of both cough and fever, and that's without the use of any antipyretics like Motrin or Tylenol. Has the virus mutated and can be contagious after someone tests positive? So there is no evidence that the virus that causes COVID-19 is mutating rapidly enough to cause substantial changes in its epidemiology. In general, it is a virus that has adapted to be fairly adept at clinging to human cell receptors, which is why it's believed to be so transmissible. In terms of antibody responses and immunity, this is currently being researched a great deal. It does appear that individuals who have been infected will have some protection from the virus, at least on the scale of a few months, thinking things like seasonal influenza type immunity. But more evidence is being gathered on this topic as we speak. Next question, my household's survivability as well as predicted COVID peak forecast. So in terms of peak forecast, there is new information. I believe this is now linked on our website, but the Institute for Health Metrics and Evaluation at University of Washington has released results of modeling work for Oregon, which does show improvements over the last several days. So the peak hospital resource use has shifted from an estimated date of April 24th to May 6th. This does suggest that efforts to begin to flatten the curve have been effective. They are currently projecting no bed shortages. However, there is always great uncertainty in these models, and they are, of course, based on the assumption that we will keep doing what we need to do in terms of social distancing and ongoing public health response measures. So takeaway here, we need to keep doing what we're doing. In terms of the case fatality rate, so meaning the number of deaths over the number of total cases, data on this is still emerging. There is a lot of information coming out, but I would say that when reading this in general, it's really important to remember that much of the data reflects outcomes in primarily hospitalized individuals because we are detecting more cases there. It's much more difficult to identify mild cases in the community. So keeping in mind that much of the data out there might be a better representation of severe disease. A recent study did report some age-based case fatality rates, so I'm going to go through the takeaways on this. For those 0 to 9 years old, the case fatality rate was 0.002%. For those 10 to 39 years old, it was less than 0.1%. For those 40 to 49 years old, it was 0.3%. 50 to 59 was about 1%. And then it starts to increase a bit from there for older adults. So 60 to 69-year-olds, the case fatality rate was reported at about 4%. For 70 to 79-year-olds, about 8%, and over 80-year-olds, 13%. Again, recognizing that this is capturing more severe disease. Next question, what is the general disease process? Why is it so deadly in some patients? Is it just like normal strains of influenza? So there are some similarities and important differences between flu and COVID. So there can be some similar symptoms, fever, cough, although COVID seems more likely to cause shortness of breath and respiratory distress. In general, the big difference is that COVID appears to be both more transmissible than flu and has a greater potential to cause severe disease than most flu strains. We don't know the specifics on why and the virology kind of specifications on why this is the case yet. It does appear to have something to do with how it's able to enter our body cells and how efficiently that's done, but more evidence on this is being collected now. I will say here too that many of the prevention strategies are similar. So still hand washing, environmental disinfection, but largely because of what we learned from SARS in 2003 to 2004, we do focus more on the potential role of airborne transmission with COVID as opposed to flu. And that's, of course, why N95 respirators are recommended for high-risk patient care. Next question. For law enforcement that gets exposed at work, what guidance do you have to keep them from potentially spreading COVID to their family at home? So important step here is that if you become ill, take immediate steps to self-isolate in your home. So ideally, this is a room alone with the door closed, sleeping away from your family at night. If you have COVID and you're concerned about high-risk exposures in your household, you have someone who's immunocompromised, someone who's pregnant in the household, you can contact your local health department to obtain some additional, more specific advice to this situation. In general, some things to consider. So while you're at work, of course, adhering to PPE, hand hygiene, and environmental disinfection recommendations. Continue to observe all social distancing recommendations in your spare time with your family. So still avoiding any community-based exposures. When you return home from work, it's recommended that you remove your shoes before entry, you wash your clothes immediately, and take a shower before coming in contact with your family members. And then throughout the house, just making sure that you are cleaning and disinfecting high-touch surfaces daily. So this, again, includes things like tables, hardback chairs, doorknobs, light switches, remotes, handles, desks, sinks, children's toys, and remind family members to clean their hands often. I will note here that we are seeing children present largely with mild symptoms. As I mentioned before, severe illness is rare in children. We don't know why this is the case yet. There are many hypotheses being put out there, but for now what we know is the symptoms of COVID-19 are similar in children and adults. However, they are more likely to present with mild symptoms. So it might include cold-like symptoms, fever, runny nose, cough, vomiting, and diarrhea have been reported in kids. There's more to learn about how the disease impacts children, but just be aware that because children may present with mild illness, it's very important that they avoid contact with high risk wherever that's possible, because again, they might be carrying the virus but not have super pronounced symptoms. I just want to note here about environmental disinfection, because we get a lot of questions about this. How can you best be cleaning your house? So the EPA and partners have released a list of cleaning and disinfection guidance, as well as EPA registered household disinfectants that are expected to be effective against COVID. If those aren't available, diluted bleach solutions, so this is at least 1,000 ppm sodium hypochlorite, can be used. As always, manufacturer instructions should be used. You should leave a contact time, so it should be wet on surfaces for at least 1 minute, and always allowing proper ventilation during and after application. And I always just put this caveat in here whenever I'm referencing bleach. As always, a reminder, never mix household bleach with ammonia or any other cleanser. This can be deadly. Next question. How long should a responder who has tested positive remain off the job? So for anyone with illness, including those that test positive for COVID and those who choose not to be tested, they should remain off the job for at least 72 hours post-resolution of cough and fever, again, without the use of antipyretics like Tylenol or Motrin. And in general, healthcare workers and first responders should be tested if they develop fever or respiratory symptoms. Next question. I am interested in best practices of quarantine and isolation for staff who have suspected exposures for COVID. So as we discussed before, there are considerations for home isolation if you become ill. In terms of quarantine, our guidance has clarified that first responders and healthcare workers can continue to work as long as they're not showing symptoms. The best practice here, though, is for really thorough self-monitoring for symptoms. So as I mentioned, twice daily fever checks is the gold standard, as well as monitoring for cough, shortness of breath, as well as other more mild respiratory symptoms like sore throat. Next question, what if I start to run a fever? How should I handle that with no confirmed exposure of COVID-19? It's a good question because there still is the risk for community level exposure to COVID. It is circulating at the community level, so this is an important thing to keep an eye on. And all healthcare providers, all first responders should be monitoring for symptoms right now, irrespective of known exposure. And then, of course, if you develop a fever and you are at home and you're not at work, do not come to work. Self-isolate in the home, as we discussed. If you are at work, don a mask, notify your supervisor, and go home. If symptoms progress and are not severe, seek appropriate if symptoms progress and are severe, seek appropriate medical attention, calling ahead to notify staff of your arrival. And if they are not severe, stay home until at least 72 hours after resolution of cough and fever. Next question, if an employee is diagnosed with COVID, what workplace cleaning recommendations are there? So I just mentioned the big ones. So frequent environmental disinfection of high-touch surfaces, good hand hygiene all around, and then ongoing monitoring for symptoms among staff. And I referenced the EPA list of EPA-registered disinfectants that are effective against coronavirus, and then the use of bleach, depending on what's available. Should all suspected cases be directed to the hospital or PCP regardless of severity? No, in general, we advise that you seek medical care if you need it. Otherwise, remain at home. We do prioritize first responders and healthcare providers in general for testing if they become ill with fever, cough, or shortness of breath. And we're asking employers to help coordinate making that testing available through primary care providers. And just note that, now that we have widespread commercial testing available for COVID, public health approval is not required to access these commercial laboratories. So that can be done, as David and Rebecca mentioned, directly through a primary care provider. Social distancing is catching on. The next step is masks for everyone and frequently cleaning surfaces. Will the state lead? Well, I'm not sure I can promise that we will get to all the surfaces in Oregon, but we will continue our public health response for the duration of the COVID-19 pandemic and beyond to make sure there are lessons learned and, of course, more pandemic preparedness in general. We continue to recommend that masking be prioritized for those in healthcare, including first responders, and this is for a couple reasons. First, the healthcare worker and first responder need is most urgent, and their contact with ill patients the most extensive. In addition, appropriate donning and doffing and use of masks do require some training. Often mask use can be a bit counterproductive if not paired with education about how to don the mask, how to doff the mask, when you should do so, for example, when visibly contaminated or after contact with a symptomatic individual, and to avoid at all costs touching of the face. Sometimes having the mask in place can actually increase the frequency with which people are kind of tugging and pulling on the mask and potentially creating a route of exposure. Next question, ability or procedure to reuse N95 masks. So in general, mask reuse should be discussed with supervisors. We do have guidance for this. It's both posted. The CDC has their own PPE optimization guidance that has some detailed information, and our clinical guidance has information about this as well. But in times of N95 shortages, the first line strategy for prolonging the life of an N95 mask is extended use. So this refers to wearing the same N95 mask and potentially also eye protection for repeated encounters with multiple patients without removing the PPE between those encounters. It's best utilized for scenarios where you're fielding multiple calls for COVID-19 patients in a row. Limited reuse is another iteration of reuse. It refers to wearing the same N95 for repeat encounters with multiple patients, but removing it between these contacts. This is really more of a last resort, as the outside of the mask should be considered contaminated, and safe donning and doffing can be challenging when providing patient care. If it is used, hand hygiene is needed before and after touching the mask, and CDC recommends not reusing the mask more than 5 times. Doffing should also occur at minimum when there are disruptions in its functional integrity, it's soiled with blood, respiratory or nasal secretions, or other bodily fluids from the patients, or after use of it during an aerosol generating procedure. Next question, are patients required to wear an N95 mask or will a surgical mask suffice? So for patients, regular masks are used. N95 should not be used for patients as they are not fit tested and it's not expected to provide additional benefit to them. or the healthcare providers caring for them. The regular mask serves as a physical barrier to droplet production. Next question, can ordinary outside clothing, if laundered, be an effective barrier against the virus, assuming long sleeves and pants? So the risk in general is that COVID could potentially contaminate, the virus that causes COVID could potentially contaminate those clothes. And if your clothes are contaminated, then the likelihood of introducing the virus into the eyes, nose, and throat via touching your face is a bit higher. That's in general why we recommend gowns to go over the clothes to just provide an additional layer of protection. And then, of course, immediate laundering of your clothes once off shift. Next question, do the homemade masks work as well as the official ones? Short answer is we don't know the answer to this. This type of intervention is really a crisis level care, last resort, as we do not have data or specific information on the protectiveness of this kind of intervention. Of course, it has some plausibility. It may help to serve as a physical barrier, but all other efforts to obtain medical grade PPE should be exhausted before their use. CDC has some guidance on this in their PPE optimization guidance. We are also making a guidance document about PPE in resource constrained settings, but handmade masks should ideally be moisture resistant, should completely cover the nose, mouth, and chin, and whenever possible should be used in combination with a face shield that covers the entire front and sides of the face, just to offer an additional level of protection. Next question, does new evidence support wearing a P100? So we don't have evidence that P100s confer additional protection against COVID, but they do provide protection, and they are considered by CDC to be a suitable alternative to N95 masks if they're available. So if you're interested in this and would like some more information, again, the CDC PPE optimization guidance has a table for PPE alternatives that are similar to NIOSH approved products. Next question, how long are we expecting to be short on PPE? When short on fitting gloves, is it better to size up or down? In terms of the duration of shortage, this is unclear. So there are many aspects of the supply chain that are being affected at this point. So both distributors and manufacturers around the world are experiencing delays due to increased demand, as well as pretty diffuse raw material shortages. New and expanded lines, supply lines are being assessed at the federal level at this point. So it's unclear whether new PPE will become available, but generally the idea in terms of sizing up or down is just trying to make sure that you are wearing the appropriate size to cover as much of you as possible. If you're wearing gloves that are too small, they are much more likely to break or have their integrity disrupted. So I would say with gloves, sizing up is a little more conservative. For gowns, you want to make sure when you're reaching your arm out, half of your arm isn't uncovered. So generally sizing up would probably be reasonable, although you have to make sure that the neck area is not entirely exposed. So you may need to tie these a little bit tighter. So a good rule of thumb is to generally, if only limited sizes are available or your type of gown changes, just try it on before you actually have some contact with patients, just to make sure you can move around, that it's effectively covering as much of the body as possible. Next question. I want to understand why testing is taking up to 1 week in Oregon. So testing times do vary, and mostly as the majority of testing is occurring at commercial laboratories, they have only come online in the last several weeks and experienced an enormous volume when they came online immediately. So commercial labs like Quest and LabCorp have added additional lab sites, and their capacity continues to improve. Their websites are the best place to check for how quickly they are able to turn this around. But Quest, for example, right now is reporting a 4 to 5 day turnaround from pickup to results. Next question, how long after exposure can the virus be detected in a test? So testing is really used only for symptomatic individuals. So it's not clear from, a general perspective about the presence of the virus for someone entirely asymptomatic. But in general, we'd recommend that testing as soon as possible after symptoms begin is the ideal. Next question, how do I stay safe in the back of an ambulance for a 1.5-hour transport time? So the biggest thing really is adhering to PPE recommendations. When it's possible, to check on your partners to assess whether their PPE remains in place, isn't visibly soiled, can be very helpful. And just checking in to ensure that they are at a reasonable comfort level and are appropriately hydrated and things like that. And then whenever possible, masking the patient. So this is huge. That provides another barrier of protection and prevents the contamination of the environment via droplet spread. Next question, PPE. I saw that some institutions are going to full face masks, presumably to conserve N95 masks should other departments. So in general, regular masks, especially when paired with face shields and eye protection, are listed by CDC as an acceptable alternative should N95s not be available. However, given the propensity for aerosol generating procedures and the close quarters of first responder-based care, N95 masks, eye protection, gown, and gloves remain the recommendation. That was a lot of talking fast. I hope I wasn't speaking too quickly, but that is all I have on my list. So I'm going to pass it back to Rebecca and David.
Thanks, Dr. Pierce. That's awesome. Can you clarify one thing real fast? We've had a couple questions asking about Advil versus Tylenol, or ibuprofen versus acetaminophen, and when to use it and when not to use it. Can you clarify that one more time for us for fever reducing?
Yeah, so you can always use fever reducers as you need for your symptoms. So not giving any guidance on the clinical usage of these, but our guidance for return to work is that you need to be at least 3 days fever-free without use of those medications. So your body needs to not have an elevated temperature free of those meds. Does that clarify?
It does. I think there's been some discussion about using them at all. There's been some stuff in the media about not using ibuprofen, but I think that's kind of been debunked. So I think it's appropriate to use both medications as fever reducer, right?
Yeah, I mean, we really don't have solid evidence. I mean, I know what's been out there a lot is ibuprofen, and the reason this was suggested and hypothesized is that there's some link between how ibuprofen works and the receptors the virus uses to get in the body. In general, these are largely anecdotal reports, and they're very hard to interpret in the context of many of the people that present to the hospital with severe disease are taking Motrin. So it's hard to evaluate the risk of those types of things in these patients. Tylenol in general has not had this kind of media attention and focus, so it is considered safe across the board if you prefer to use that one. But more research is being done on this, but there has not been anything conclusive to date that suggests that Motrin cannot be used.
Thank you. Okay, Dr. Learfield, you have some questions you can answer.
All right, thank you, Dr. Pierce. It's a hard act to follow. So I'm going to just start at the top of this list. The question is, can we finalize a no transport order statewide? Crisis care guidelines for EMS will provide a structure to make decisions about who to transport and to where. These decisions need to be regional in the context of the healthcare system, the regional healthcare system, with regional triggers. There is no intent to have a statewide no transport order, as surge in one part of the state may look completely different, both spatially and temporally, than surge in the other part of the state. So there are guidelines generic guidelines about what triggers you might use and how you might modify both your response and transport. But there is going to be no statewide order for this. Does the OHA have a plan to temporarily waive internships for EMS students so that they can help with the inevitable surge? Again, I'm going to interpret the intent of this question. Trainees who are currently licensed and in good standing can provide care in their current provider level. For instance, a paramedic student who is already licensed as an EMT or an advanced EMT may practice as a EMT or advanced EMT. There is no intent to waive internships and automatically sort of graduate people who have not completed their training program. EMS works, was that Liz, or are we not doing that one, these next two?
We talked about that one.
Are we going to talk about these two?
Those are the ones I talked about earlier.
Okay. Will we be reactivating retired EMTs? There's no plan at this point to have unlicensed EMTs or any unlicensed healthcare worker provide patient care, but they may volunteer in other capacities.
And we do have a reinstatement program that's in place for anyone who does want to reinstate.
Reinstate.
Mm-hmm.
Will OHA EMS relax 911 generated transport rules to allow for alternate site patient transports during COVID-19? So the OHA does not have rules that require EMS transport patients to hospitals outside of trauma. We do have rules that trauma patients must go to trauma hospitals. The main issue here is that under normal regulatory structure, CMS will not pay ambulance agencies to transport to alternate destinations. There is a new blanket waiver from CMS announced this week, where it will be possible to get reimbursed to transport to alternative sites. There'll be a webinar on this next week.
Next week.
On all the details. For the transport of trauma patients, we are preparing waivers should that become necessary to transport to the closest hospital instead of a specialty hospital. These will be outlined in crisis care guidelines, what those triggers might be. Will there be a mandatory draft of EMS providers if the COVID-19 pandemic is severe and prolonged? There's no plans to conscript EMS providers. However, should you wish to volunteer and you are a licensed healthcare provider of any kind, you may sign up with ServOR, which is the Emergency Registry of Volunteers, Oregon. Mm-hmm. And we'll provide a link to that website. There's a question that says, the ability or procedure to reuse N95 masks. We are going to link you to the CDC's strategies for optimizing the supply of N95 respirators. There's also another question that I'm going to link in with this that says, how long can I use my N95 for? Under normal circumstances, it's one N95 per patient per provider. If you get into contingency strategies for your PPE use, there's a lot of strategies that I won't go through now, but I'll refer you to the CDC strategy for supplying, optimizing supply of N95 respirators, where it will take you through a progressive strategy from contingent to emergency operate, from standard operations to contingent to emergency operations, and how you should and what strategies you should take at each step. Are we gowning up for all calls to skilled nursing facilities, long-term care facilities? That's a complex question. Long-term care facilities and skilled nursing facilities have been issued guidance to coordinate with their local EMS ahead of time. So if there is a 911 call to one of these facilities, hopefully you'll have communicated with them ahead of time to communicate what the procedures were going to be, How are they going to inform you if the call is for an infected patient versus a trauma patient, and what your expectation of them is, what their expectation of you is for what type of patient. We will hope that you will come to agreements with these long-term care facilities on whose roles and who has the role and responsibility for each step of this. The question, test fitting requirements for N95 and contingency level and crisis levels, rural and frontier agencies and high-risk responders. So again, agencies should develop crisis care guidance for PPE's use in general, specifically for fit testing. If this is a question about whether it is okay to use them without fit testing, I think there's a clinical component of that, and then there's a regulatory component. The regulatory component would fall under Oregon's Occupational Safety and Health Administration, so you'd need to contact them on the regulatory component. For the clinical component, the question is it better to use an N95 that's not fit tested versus no N95 at all? I would think probably yes, but I couldn't cite any published literature on that. What clear messages of best practices can we send to the line staff when responding to law enforcement calls? So we have specific guidance for law enforcement officer for healthcare exposure and work guidance, and that's right under, on the same webpage, right under the healthcare exposure and work exclusion guidance for EMS. What is the best method to doff decon before entering the cab to drive after contact with a suspected COVID-19? Again, this is sort of a visual answer. We have linked to the CDC's infographic about the sequence for putting on and doffing personal protective equipment. There's a question of, will we have enough or appropriate PPE in Oregon when things get worse? This is unknown. Our current models show that the peak would be about a month from now. We are receiving shipments from the Strategic National Stockpile. Will it be enough? Really depends on just how much we flatten the curve and how long we can maintain our social distancing measures. There's a clinical question. What are the recommendations for safe transfer of the potential COVID patient on CPAP BiPAP? This procedure, CPAP BiPAP, is more likely than any other pre-hospital intervention to aerosolize respiratory pathogens, and so it should be avoided if possible. If unable to oxygenate a patient without positive pressure, consider supraglottic airway versus endotracheal intubation. What are we doing to address cardiac arrests in advanced airway placement? This is up to the individual medical director. If this is a question of should we do normal airway management versus alternative airway management, there's no evidence that either supraglottic airway or endotracheal tube improve or detract from survival in cardiac arrest, or there's no evidence that either one is superior or inferior protecting healthcare workers from infection. Are we going to do field testing? This field testing, and I'm going to interpret this a little bit to mean, is EMS going to do community paramedicine type nasal swabs for COVID testing? The Oregon Medical Board published an emergency rule effective as of today, and there's a state protocol for doing this, but it's a multifactorial decision. It must be made in conjunction with your local public health authority, your EMS medical director, and of course the availability of the testing kits to include the swabs, transport medium, reagents, and the actual PCR tests. All of which have been known to be in short supply, depending on where you are. So the short answer is you could do it from the state perspective, but you need buy-in from multiple other authorities. There's a question or a statement. We have hospitals telling us they will no longer provide test results on persons under investigation. We bring to them, what can we do about this? So there's no legal requirement for hospitals to do this. Local public health authorities in their investigative guidelines have been instructed to notify EMS if they transported a positive case. So that's how you should be getting your information, is from your local public health authority. Why is it taking so long to hear if a patient we have transported has COVID? I think Dr. Pierce addressed this, but we'll go over again. You know, we've definitely seen cases of patients who were asymptomatic when they were transported. 3 or 4 days into their hospitalization, they become positive. They're negative for flu and other things. A COVID test is sent. 3 to 5 days to get the COVID test back, and you're easily a week after you transported them before anybody knows that they have a positive result. And then they have to track EMS down, or local public health has to track EMS down and inform them. I hope that answers the question. Okay, I think we've worked our way through all of them. Do you have anything else for me, Rebecca?
Oh, we have quite a few questions that we weren't able to get to on the webinar, but I need to be respectful of Dr. Pierce and Dr. Lehrfeld's time. So if we didn't get to your question today, please note that we are monitoring these, and you can email us, and we can try to email you back directly with questions that were answered. Again, certificates will be issued in the email after you close the webinar. If you're viewing in a group, you can create a roster, or you can fill out the survey. CMS webinar will be next week. And thank you for your time. Thank you, Dr. Pierce, for your time, and thank you everyone for joining us today.
Thank you, Rebecca.